Thank you.
Thank you very much, Juana. Good morning, everybody. Really want to start out by thanking you for everything you do. I've said many times to this group that every time I hear a comment about successes in the SICU and in the trauma center from people in the administration, you know, whether they hear a story from a patient or whether they hear about our quality indicators, I always say to them that, and to everybody that I interview for jobs or everybody that interviews here for fellowships, I keep saying the same message. And the message is that the success of this trauma program is not about the doctors, it's about two factors. One is that the trauma center is not in the emergency department. Very different than other trauma centers in the country. There's only 3 other centers or 4 other centers in the country that function the way we do. But the location of the trauma center wouldn't make a difference if it were not for the people that work in the trauma center. And have the quality of nursing that we have, taking care of trauma patients on admission and then following up with their care in the ICU, providing nursing continuity of care, is really critical for our successes. So we take it for granted most of the time, and we don't thank you enough, so I always make sure that I deliver the same message consistently, because this is the best group of nurses in the hospital. Our unit is the best ICU in the hospital, and the trauma center shines because of the fact that it's in the surgical ICU real estate. So I cannot thank you enough for everything you do and for keep us doing the right thing every day for the patients that come to us. The good news is that, as most of you know, if some of you don't know, we collect a tremendous amount of data, which is mandated by our contract with the County of San Diego and mandated by the American College of Surgeons, because the trauma center is verified by the American College of Surgeons, a level 1 trauma center, every year. And similar to the JACO process, the JACO shows up to the hospital and looks at anything they want to look. The trauma center goes through a very similar process, a little more structured, a little lighter than the JACO process, but comprehensive nonetheless. So we collect this tremendous amount of data and submit it to a national database. And from that national database, they develop, the American College of Surgeons develop a program that's called TQIP, the Trauma Quality Improvement Program. Very similar to what's being done in cancer or in general surgery with NISQIP. And these are opportunities for us to submit our data and be benchmarked against national standards. So basically, it's not a ranking of trauma centers, but when you look at this data in great detail, the quality indicators that they are looking at to compare trauma centers amongst themselves indirectly creates a rank. So we've been participating in this project for several years. We were part of the pilot just because of the quality of this program and the reputation in terms of the trauma registry and the trauma center. And the program has been active now for 5 years. And I get reports every 6 months, and Juana hears about this with Madeline in our division meeting every other week. And we continue to do very, very well in terms of our outcomes and in comparison to other trauma centers in the country. We've always been at the top 5 trauma centers in the country. This is really remarkable. It's very, very hard to be at the top, to get to the top, and to stay at the top for so long. And I think you know, it attests to the maturity of the program and to the process that you all participate in the trauma center, doing the same thing every day consistently enough. Obviously, there are always areas for improvement. So we look at it as opportunities for improvement. I'll just give you an example. In the last report, our incidence of pneumonias is higher than the national average. And when we drill it down, our pneumonias are coming from the majority of patients with traumatic brain injury. And then we drew it further down, and we realized that our time to tracheostomy is very variable. So this gives us an opportunity to either improve or at least study. So I told the group that I don't care if we are part of the early tracheostomy or late tracheostomy strategy. We got to be part of one and be consistent and see what happens. Obviously, I have my personal bias. I think that people that we anticipate are going to be on the ventilator for 5, 7 days, 10 days, or 2 weeks, and we kind of know who they are, we should do early tracheostomy. I think it helps with pulmonary toilet, helps cleaning up the airway, helps with weaning from mechanical ventilation. So that's my bias, but the group has to make a decision about this. But this is an example of how you get your data, compare yourself to others, look at areas that you see some opportunities for improvement, drill down and figure out exactly what you need to do. So lots of projects like that are derived from this benchmarking, this national benchmarking. But the good news is that we remain one of the most efficient and one of the best trauma centers in the country as far as our quality indicators go. As you know, there is a tremendous pressure for us now in this hospital, in healthcare in general. Everybody has heard about this value proposition that comes along with Obamacare, that it's not about providing good care anymore. It's about providing good care, being able to measure your quality with very objective, specific indicators. And we thought we've done that pretty well. You know, this trend in medicine about quality we are hearing about quality in this hospital a lot in the last 8 years, but trauma centers have to measure quality performance based on quality indicators for 30 years. So we were way ahead of the curve, and this group knows about this more than any group in the hospital. But the pressure is on now because that will be linked to payments. So obviously, it's not about just providing great care and having great quality indicators, but it's about providing care at the lowest cost possible. So now value is quality divided by cost. That's what the federal government is saying to us. So in a program like ours that's highly efficient, that we try to move as fast as we can, there are very few opportunities for decreasing cost, primarily because our qualities are already very high. But there are a few opportunities. So one is trying to decrease the number of readmissions. You know, a lot of patients go and come back, and by default they are readmitted by the emergency department, by our team in the emergency department. And sometimes those readmissions are not appropriate. They use a bed, they increase cost. That's one area that we are working on. And the other is trying to optimize all the processes after admission to decrease length of stay. So we are keeping a database, and you guys don't feel this directly, but sometimes you do. But primarily when patients move out of the unit and they are ready to go home, particularly the short stays, we keep them an extra day because we don't get reads from radiology, we don't get PT and OT clearance, and there's all those supporting services that are not there all the time to provide the care that we expect to send the patient home. So those are opportunities that we as a group have been working on to improve our efficiency. A day less in the hospital or a few hours less in the hospital definitely decrease cost, and the program will look a lot better. So we are going through interesting times, but the pressure is really on to improve quality and decrease cost and align with national mandates from federal government, because they will link it to reimbursement. Just to give you an idea, if I do an operation, patient goes home, comes back with a wound infection, has to be readmitted, we don't get paid. Those are the rules from federal government. They're starting with pneumonias, they're starting with DVTs, and now they're going to surgical site infections. So all those vigilance on those things like DVT prophylaxis and head of the bed elevation and good pulmonary toilet and aggressive chest PT and incentive spirometry, all those things will hopefully decrease the incidence of pneumonia and help us with our indicators. But it's a lot of pressure now to measure those things in greater detail. Unfortunately, the hospital doesn't have a great ability to measure those indicators with accuracy. So I've always, fighting the numbers that I see in a number of meetings because they usually don't reflect what the program measures, and we have a very precise way to collect data. We have 5 people in the office collecting data at any time. So, but regardless, instead of trashing the methodology of collecting data, we need just to be proactive, and the more we do, the better care we provide. So that's what's going on in quality. This year is our index year. Trauma verification again is next March. So we go through this JACO process that I just described to you for the trauma center every 3 years. And what does an index year mean? It means that is the year that we need to provide data for them. So all trauma admissions in this calendar year will be made available to them, and they can look at anything they want. So they can look at all the OR resuscitations, they can look at all deaths, they can look at all pneumonias, they can look at anything they want to know about our protocols and process of care. So the site visit's a 2-day visit. It's in the beginning of March. Juana is always part of it. And they not only look at records, but they site visit the facility. They can walk in the blood bank, and first person that they see sitting there, they say, "Tell me about the massive transfusion protocol." They have the right to do that. So they can come to the ICU and say, "Tell me about your weaning protocol," or how you interact with the trauma team during rounds, or whatever they want to know. We've been always very, very prepared, but it requires a tremendous amount of education, continuing education, particularly not in the ICU, but in the blood bank, laboratory, radiology, etc. So we're working very hard this year to be ready for March. I'm not anticipating any problems for our verification. I don't see any major red flags. But if I see something, I'll obviously let you guys know. The burn center goes through the same verification process. Theirs is a little late in the year, but they are in the 3-year cycle, and it so happens that it's the same year as us. So they will probably do theirs in May or June. Since I mentioned OR resuscitation, because of all the financial pressures that we face in the hospital, building a $1 billion hospital in La Jolla is it's a problem for us because of the investments that are made in this hospital are less. There's less availability of resources. We'll get through that, but in the meantime, obviously there is pressures in reducing cost at any cost. And it's a luxury for us to have a trauma bay in the operating room, quite frankly. That's how I look at OR resuscitation. Every time they try to take it away from me, saying you don't need this OR, I said, no, I don't need this OR. I need this trauma bay in the OR. So I sell the idea that we have a 5th trauma bay in the operating room, and that is what makes us excellent. So the few cases that go there have 20 to 30% more survival. And we've studied this extensively. We wrote papers about it. So I show it to them, and they leave me alone. But obviously, there is always pressure to either create more capacity for more surgeries using that operating room, or decreasing the availability of staff in the operating room that's there just to staff an OR resuscitation if needed. So I would ask you to, if you get the phone in the trauma bay, if you are the trauma nurse on that day and there is a patient that has a systolic of 80, make it an OR resuscitation. If we don't use that room, you're going to lose it. And I'm not going to say let's use it inappropriately. Let's use it for the right patients. And if there is any questions, you know, we should err on the side of taking patients to the right place rather than to the wrong place and then being late on the game. So just a side comment about OR resus. What's new in trauma? In the last 5 years or so, you've noticed a significant difference in the way we try to resuscitate trauma patients, giving less crystalloids, restricting some crystalloids during the initial resuscitation, and trying to be more proactive in giving blood early. And then you heard the story from the military that people were dying of coagulopathy and anticipating post-traumatic coagulopathy that happens very, very quickly. They came out with that idea of every time you give a unit of blood during the resuscitation, you should give a unit of FFP. So the concept of one-to-one resuscitation is a unit of blood, a unit of FFP, and a unit of platelets, in our case, a 10-pack of platelets. And that's still going on. Lots of research being done on this. Obviously, coagulopathy is a major focus. So this is the stuff that's going on in 5 years. A little bit of evolution in the last year with a better understanding that platelets actually may be as important as FFP. So they should be given as a part of the initial massive transfusion protocol. And that's how ours is written. So lots of interest in resuscitation in general, in researching trauma, and the military is interested in looking at alternatives to blood and FFP, and they are looking at dry blood, they are looking at dry plasma, which is basically a powder that you reconstitute. So there's some opportunities there for development of new resuscitation fluids that would have the same properties of plasma to correct coagulopathy, same properties of blood to carry oxygen. So this is a work in progress, and we've seen some good stuff coming out.
Would it have a longer shelf life?
Yeah, you just grab from the shelf and reconstitute and infuse, and that's the beauty of it. You don't need to conserve in a freezer, or it's not preserved based on temperature, and it can be reconstituted immediately. So lots of animal studies showing good response in terms of coagulation factors and correction of coagulopathy. So we will see some of that stuff perhaps being tested clinically in the near future. So resuscitation coagulopathy remain the focus. What's the new kid on the block, and we've been working actively on this, and Dr. Doucette has been instrumental in developing this program since he's responsible for all the education the educational courses in the division, ATLS and others, is a thing that's called rebola. Rebola is an acronym for placement of through an endovascular approach, like a Seldinger approach, through the groin, like we place a central line with a guide wire, placement of an intra-aortic balloon. So instead of opening the chest and putting a clamp in the aorta, doing a resuscitative thoracotomy, the idea is to do the same, but through a less invasive process. So by putting a catheter that has a decent sized balloon at the tip in the abdominal aorta, right at the diaphragm, for patients that have significant hemorrhage in the abdomen, either from bad liver injuries or splenic injuries or pelvic fractures, and avoiding a thoracotomy that adds a tremendous amount of morbidity, pain, and big incision, and it's a tremendous insult, is very attractive. So I've seen this used clinically many years ago when I traveled to one of the trauma centers in Yokohama in Japan, and I saw a third-year resident receiving a patient that was in a car accident and had a horrible pelvic fracture. This lady was really dying in front of us, and I was getting anxious and saying, when are you going to crack that chest and take her to the operating room and pack the pelvis, do this, do that. And this resident, third-year resident, very calmly grabbed a catheter from the shelf, stuck her groin, float the scatter, measure outside without ultrasound or anything, float the scatter, inflate the balloon, and her blood pressure goes up and normalizes. And then they have time to resuscitate, to give blood, to take her to IR, to get the pelvis embolized. This lady survived. So Japan has the largest experience in the world. They actually started with a 12 French catheter, which is pretty big, and you can insert a 12 French catheter percutaneously. You need to dissect the groin, and they had some problems. Then they evolved to an 11 French catheter, which is being approved for clinical use in the United States as well. That's still very big, and they had some problems because you imagine these people lose 3 liters of blood, they develop tremendous vasoconstriction. So an artery that's already small, probably the size of the catheter, becomes half of that size. So you're shoving a catheter that's twice the diameter of the artery at that time, and they had problems dissecting the artery, creating arterial injury. There were some limb losses because of thrombosis. But yet, the effectiveness of the method is being demonstrated. Now, the last time I went, they gave me one of the catheters. They put a educational session just for me. They were very kind to show me that they developed a 7 French catheter, and the company came, brought some mannequins, and we did some hands-on training, and it's really sweet. They have a 7 French catheter that's not bigger than the ones that we put in the groin most of the time, and you slide that baby in and inflate, and it's just amazing how easy it is. So they've done probably, in the whole country, they've done probably about 180. They presented their data in our trauma meeting here in the United States in September. They presented their initial experience with 50. This paper is coming out soon in Journal of Trauma. And at the same time, a couple programs in the United States, particularly the US military, start developing their interest in this, and they are also developing their own catheters. That Japanese company requested FDA approval to commercialize that catheter in the United States and has not been granted approval yet. Obviously, it's a Japanese company. They got to do 300 tests, and the FDA really creates a lot of impediments for this. But the good news is the technology is available. It will come. And it's just a matter of time for us to have the right catheter. I would be very concerned if we have to use the 11 or 10 French catheter clinically all the time. I think under very controlled circumstances, like in an OR resus, that you are in the right environment, you have the instruments to open the groin, dissect the artery, do it under direct visualization, I think it's okay. But I hope that we are going to have a 7 or 8 French catheter in the United States in the market. So this is really, really brand new, and I want to bring it to your attention. And because of Jay, we had already our first training on a catheter. We did a cadaver session. We tagged along to one of his courses using cadavers, and he brought a few catheters, and we did the first training, and it's really feasible to do. And I think this is going to be one of those things that's incorporated as part of the initial resuscitation of a patient in shock. And this is being used more and more. So, you know, the guy that comes in with a systolic of 80, you may not need to cross-clamp the aorta, but if you have that balloon and you inflate that balloon and decreases the duration of hypotension until the blood comes and you resuscitate and you make a decision to operate or remove the spleen or whatnot, I think that's going to be very positive for patients. So it's going to happen. And the idea for us, because if we need to do this in OR 11 or in the trauma center, is to avoid using fluoro, like most centers in the United States are using it, are doing, and try to use ultrasound. And that's where Jay comes in, because he's the ultrasound guru, and he will train us to identify where the balloon is based on ultrasound. And once the catheter goes in and you position the balloon in the right spot, you know, it's a no-brainer from there. I think I'm going to stop right here and let you guys ask questions.
Just with the rebola thing, since you're placing it in an artery, there's no, does it have any infusion? Can you infuse the catheter?
No.
Right.
I mean, you can, but since the catheter, the balloon is about 3 centimeters from the tip of the balloon, so you'll be infusing above in the aorta, which has no purpose. So it's not used for infusion, but using for aortic occlusion primarily.
You don't cut a false supply to the bowel and everything. You cut a false supply?
Yeah, when we put a clamp here, we cut all the blood supply anyway to control the bleeding, right? So it's a temporary measure that will allow you to raise the blood pressure to maintain cerebral and cardiac perfusion until you start resuscitating and you get control of the hemorrhage. The same way we did the thoracotomy, when we are done, we remove the clamp, you deflate the balloon. The thing about this, though, is that you can inflate and deflate a little bit, inflate again, deflate. So you have, if you think that you're inflated for a prolonged period of time, you can deflate a little bit, allow some perfusion, and then reinflate again. It gives you that flexibility.
Not with that tender left French, though. I mean, taking up the whole vessel.
No, so the discrepancy between the size of the artery and the catheter is in the iliac artery as you go in. Once you're in the aorta is this big, right? If it's vasoconstricted, it's 1.5 centimeters, so it's much bigger than the catheter. So the idea is you deflate a little bit to allow perfusion to the kidneys, to the intestines, but then if the blood pressure drops, you inflate again. Gives you that flexibility, which we didn't really had with the thoracotomy. You know, the clamp is on, the clamp is on. So, you know, I cannot tell you about outcomes yet, but the Japanese experience is that's very positive. So maybe a cool thing to pay attention. Yes, Dana?
How long is it safe to have it occluded? I mean, is this something the research nurse should say you can have it?
Oh yeah, so great point. So again, processes, right? Once this goes in, we got to monitor for how long it's being occluded. So time of insertion, time of inflation, time of deflation is all have to be monitored like a vital sign. I don't think that the time of inflation is any different than the clamp in the aorta. You know, most of this literature suggests that you could keep a clamp in the aorta between 45 and 60 minutes in a massively hemorrhaging patient. 60 minutes is a long time. Most of these people, as you all have experience with, if you don't fix the bleeding, then they die. They die of exsanguinating hemorrhage in the OR. But the fact that it can be done at the point of entry and is less invasive, I think it's a tremendous advantage. What else? Yes.
I'm going to go back to quality.
Yes.
I think one of the big frustrations we have is radiology doing reads on stuff. We have people sitting in the back for hours waiting for reads. And it just seems to me that if it's a stat procedure or CT or whatever, it should be read within hour and a half outside at the most.
So you're talking about wet readings?
Any read.
Yeah, the resident reading or the initial reading.
Because it just, you know, our flow gets stopped because this happens, and I'm just wondering, you know, why, if it's a stat read, why is it taking so long?
So this was discussed in our multidisciplinary with radiology on Tuesday, and for whatever reason, the trauma had priority for all the reads in the past. That's why we got them so fast. And for whatever reason now, they put the ED before us. So I argued that that was not the right thing to do, particularly because we don't have a mechanism to flag the ones that really need a read. So what we are working on now is to create a mechanism by which the emergency department, when they request a film that they need a read, and in general they don't look at the films they order, which is another issue, they will be able to flag, this is emergency, I need a read immediately, instead of putting all their films before ours as a priority. So they will have to make an effort to prioritize what they can read, and I think that will help us. For us, I told Tudor Hughes, who is the radiology liaison, that there is no trauma film that's not a priority. Whether it's a priority for disposition from the trauma bay, or whether it's a priority because we need to discharge the patient and decompress the hospital. So we are working on processes to do just that, because we are also feeling the pressure, getting a page every morning saying Hillcrest is full, discharge immediately. Well, our patients, we know everybody at 8 o'clock that can be discharged, they don't get discharged until 3 in the afternoon because they don't get a read. So I took this to Angela Socia yesterday as well, and it's going to be part of the radiology goals for the year to develop those processes and see if there is any improvement. So I'm working on it. What else?
Can we go back to OR resus criteria?
Sure.
Just maybe what, if those criteria will change at all, or to talk about, like, at least from our end, how difficult it can be sometimes with the reports that we get, and we're supposed to make these calls based on that.
I did have one the other day that it was a cut to the neck, and they told me a foot. So a slice to the neck where he almost got killed by his barber is bigger than a foot being cut. So of course I didn't make it an OR recess, but I mean, he should have been, right?
Well, I think Rose, who is our OR resus specialist, we'll talk about it today, but in a nutshell, there's basically 5 indications for operating room resuscitation, right? So penetrating injury to the neck with impending airway problems. So if you hear big hematoma expanding, make it an OR resus. It may be hard to intubate and get a surgical airway. Penetrating injury to the trunk with hypotension. Indication for OR. Systolic 80. We could make it systolic 90, but then we're going to see a lot more OR resus that we don't need to. Blunt injury with hypotension unresponsive to initial fluid resuscitation. So if you hear car crash, systolic is 80, and we gave 500 cc's, it's still 80, but that's an OR resus. Traumatic amputation is an indication for operating room resuscitation, not because of the ability or opportunity to replant, but the bleeding control. And what's the 5th? Penetrating neck, penetrating trunk, blunt injury with unresponsive to fluid, and traumatic amputation. Those are 4.
I think those criteria are clear. I think the problem for me and for probably a lot of my colleagues is actually getting reports that give us that information. So I guess I'm more interested in how we can clear that up. Like, how do we communicate with the medics in the field to give us those specific things, and then how do they get that information to the MICN, which can then get to us? Because there's a lot of telephone game going on with that whole process.
Yeah. Right. So before I answer your question, the 5th criteria is traumatic arrest. So CPR in progress. So we don't talk to the medics, right? We don't have a way to communicate with the medics. Ideally, if you hear no blood pressure, the subsequent question should be no blood pressure because you did a measure or because it's 0, right? And those are the cases that you have to use your judgment and look at mechanism, look at other vital signs if they are available, tachycardia, level of consciousness, and potential injuries that they've described to you and say, I'll be on the safe side and make this an OR resus. The MICN won't know. If you ask the MICN, did they measure the blood pressure? She won't know. She's transmitting to you what she heard. So I think that putting together mechanism, maybe tachycardia, maybe level of consciousness and external injuries that they've described may help you make that decision. But I agree with you. There is a gray zone there that we are going to always have a case that should have gone in retrospect, and that's okay. But my message to you is that I would err on the side of calling more than less if you are in that gray zone. Because really, when we look at this data and we look at this in any way you can imagine, but patients that have a lethal injury, that are normotensive or not, patients that have a lethal injury that don't have a systolic less than 80, that go to the trauma bay, then go to the operating room, compared to patients with the same injuries that present with hypotension that go to the operating room directly, these guys are sicker, right? They survive 20% more. So it is about one variable, time to hemostasis. How quickly you can put your finger in that bleeding vessel. And when we look at heart injuries, vena cava injuries, and aortic injuries, all three lethal injuries survive with 20 to 30% higher if you are made an OR resus. So if I hear gunshot wound to the abdomen, systolic 81, I probably will make that guy an OR resus if I'm picking up the phone. Doesn't meet the criteria, but it's common sense, right? And on the other side, there will be the elderly 79-year-old that was walking the dog, tripped and fell, hit the head, and has a systolic of 79. That may not be an OR resus. I understand that too. So there is that zone that we need to use judgment. I will guarantee you that no one, and the team has been instructed very clearly, that no one will criticize any one of you for making an OR resus a patient that doesn't have to be there. That's not about us debating this. This is about patient safety and care. So you use your judgment, we trust you.
What about when the MICN want to make the patient an OR resus, but it actually don't meet the criteria that we have? And they want to make an OR resus. Do we go with it? We don't know. I don't believe we don't.
You are the only person with the authority to make a patient an OR resus, not the MICN. That's not the medic's call. That's not the MICN's call. It's your call.
So along that line of, I was going to ask the same question that Sandy posed. But sometimes, so we are given that opportunity or the privilege to call that for an OR resus. But sometimes, there's a doctor there and we run it by the doctor and the doctor says, no, because of manpower or we already have a resus in progress here and we have 3 resuses, we don't have enough. Where do we stand with it? We know that the patient needs to go to the OR. It definitely is an OR resus.
Right. So let's address the MICN issue first. If the MICN says to you, no, I want to make this patient OR resus, you got to ask them, what do you know that you're not telling me? What else do you know that I need to know? So help me make that decision and support you. But if you told me the whole story and I'm telling you this doesn't meet criteria, this doesn't meet criteria. So I think that issue is easier to solve. And if you guys are being pushed by them, we meet with them every month in the radio room, in the base station meeting. We can address that issue. They know clearly, and Melody knows this, that it's not their prerogative to call to decide on destination. It's your prerogative. Now, what we've said historically is that if we have patients in the trauma bay and a borderline patient comes in, they just say, this guy could be an OR resus, doesn't look terribly sick, it's not a gunshot wound to the chest, it's not somebody that you know is going to be operated on immediately. I think it's a matter of judgment, because splitting the resources sometimes compromise the care of those that are already there. So we said, if you're in that gray zone and you're not sure, but you don't anticipate major operation immediately. So again, if it's not a penetrating injury with shock, I would say go to the trauma bay because all the resources are there already immediately available, rather than to sending them to the operating room and splitting the resources. And the resources are all the resources, right? Nurses, doctors, blood, and everything else, radiology. So when you have active sick patients in the trauma bay and somebody comes in borderline, I would bring them to the trauma bay so we can take a look at all of them and prioritize.
Comes out to be like, why, you know, when you attend, say, the trauma conference on the Tuesday, and it's shown there that, you know, the question always arises that, you know, why did the nurse call for an OR resus? And the nurse who made that decision cannot be there to justify or what happened before this presentation.
Right.
So I'm sometimes I'm caught between, you know, protecting the nurses and justifying their action and not knowing exactly, you know what I mean, you know, it's being presented.
So I'm just telling you don't need to protect the nurse because we are on the same team. I guarantee you that no nurses will be criticized for calling an OR resus that's unnecessary. It's your judgment. You are in the front line. You're picking up the phone. I am not the guy picking up the phone. How can I criticize your decision? You have the criteria in front of you. You know what are the few exceptions. You know, multiple patients in the trauma bay, gray zone, not significant mechanism, not penetrating. You guys have enough experience to make that decision. Why? The exercise that goes on in the trauma conference about, you know, case review for quality and etc. is nothing but an exercise. Because if we identify an opportunity for improvement, and I actually am much more interested in those that should go to the OR and didn't, rather than the ones that went and were not necessary. Because I understand, you cannot, it's not always a clear cut, right? But the ones that you hear, gunshot wound to the abdomen, pressure of 75 doesn't go, I'm interested in that one. Because there is an opportunity for improvement there. So,
the one that has a pressure of 60 and a heart rate of 140 that stabbed 6 times in the abdomen, and yet the guy's like, the attending or the fellow that's there says, I want to split up the team. But you know that that's what the patient needs, and that's when we have, you know, so what do I say? Too bad, if he needs OR resus criteria, you need to take this patient to the OR. I mean, is that what we do, or do we, you know what I mean?
That's happening a lot at night.
Is it happening?
It's happening a lot at night.
Okay.
We have a lot of patients, and then there's one that comes up that's an OR resus, and it's like, well, I don't want to split the team.
And is this coming from the attending or from the residents? Because the residents have no business into this. By the way, the residents have no business on anything else anymore.
It's not from the residents.
Okay.
They don't get to make that.
All right, so we need to educate the attendings again.
Can I propose that if you run into these cases, you know, we hear about it after the fact, but shoot Dr. Coimbra an email and say, I felt this patient met criteria, and Dr. X, and I would make it the attending, had discussion and their decision was this. And then Dr. Coimbra can...
Yeah, well, I'll address immediately. But I'm glad you guys brought this up because there is an opportunity here for us to educate the new faculty and the fellows. And I'm not sure that new fellows know it enough. All right, I'm gonna stop. I know you guys have a busy day. I wanna thank the speakers for coming, and any problems you have, just shoot me an email, talk to me, and we'll try to address the best way we can. Thank you.